Tonight's program, an update on advances in the management of liver cancers, an interactive case-based discussion. We'll bring a little more focus to the increasing role of immunotherapy for both advanced and early stage hepatocellular cancer. Tonight's discussant is Dr. Tanya Saab, professor of medicine at the Mayo Clinic in Scottsdale and leader of the GI oncology group. Tony, go ahead.
Thanks, Charles. Great to see everyone on the call, a lot of great friends. And so we'll go through some of the updates in managing liver cancers, and we'll talk a little bit about some data that was recently presented also in the adjuvant setting, the first positive study in the adjuvant setting. We'll talk briefly about that and what kind of implications it may have on our practice. But to start off, this is the first, frankly, major change in the BCLC algorithm, and I think the biggest change is actually here with the systemic treatment, and it actually interestingly encompasses both, the typical advanced stage C and then stage B, specifically those diffuse bilobal liver involvement, and including atezobev, durvalumab as options for ineligible patients, sorafenib, lenvatinib, or even durva single agent, and then cabozantinib and regorafenib with also ramucirumab in second line, and so it's interesting to see how busy this piece has become. The last iteration of this was essentially a couple of drugs in this box. The other point of discussion, and I think that's going to be important as we go through our discussion to understand, because that had been an eligibility criteria and an inclusion criteria in one study and exclusion in a couple of studies, and primarily focusing on main trunk portal venous thrombosis or involvement with the tumor, and that's VP4. That does have implication when included or when excluded. Involvement of this area essentially indicates a higher risk of bleeding, significantly higher, but also worse prognosis. So excluding it have some implications on the interpretations of the clinical trials, whether it's efficacy, but also toxicity. Now, what we've seen mostly with the immune checkpoint inhibitors, overall based therapies, is with single agent PD-1, PD-L1 inhibitors, you see a range of 10 to 15% response single agent, and they tend to be durable, but the studies that essentially took on single agent IO did not pan out to be any better than TKIs, than sorafenib specifically, until the advent of dual IOs, whether adding a VEGF inhibitor or adding a CTLA-4 inhibitor, and we'll go through the data, which enhanced the response rate, but also improved outcomes, PFS and OS. So when thinking about, two main ways to actually enhance the activity of IO-based therapy. So the first is essentially adding an anti-VEGF agent to a PD-1, PD-L1 inhibitor. So what anti-VEGF agents do, as you would imagine, they just improve overall circulation around the tumor, so enhance delivery of T cells, and also, improves the dynamics of good to bad immune cells, and so making the milieu more favorable, and therefore, when you add PD-1, PD-L1 inhibitors, you get an enhanced response. Bevacizumab itself has a single agent activity of about 13%, and targeting PD-1 alone has about 15% response rate. And the early indicators was that if you combine the two, you actually see some interesting responses, and that led to IMbrave 150, a study that randomizes patients to atezobev versus sorafenib, randomized 2-to-1. Two important aspects of this study: it did include patients with VP4 tumor, but it also mandated an upper endoscopy for patients, and essentially This has to be obtained within 6 months of starting treatment. And the patients essentially that had grade 1 or less varices were included. Those that had stage grade 2 plus varices had to be addressed and not bleeding at the time of entry. So they weren't excluded, but they had to be addressed. In this study, survival was positive. At the median 19.2 versus 13.4 months with a hazard ratio of 0.66. And if you look at the tail end of the curve, you can see that about 40% of the patients remain alive beyond the second year, actually going into the third year, which is pretty impressive. For what we know about this cancer, right? And then the PFS was positive, 6.9 versus 4.3 months at the median, but a hazard ratio of 0.65. And you can see separation starts really early in the first month and a half and is maintained even 2 years later. You still have a benefit. You can see about 20% of the patients will remain progression-free and alive on atezolizumab and bevacizumab. There was no time limit on atezolizumab, meaning, patients continued as long as they were responding to the treatment. Now, this is a disease where we've, typically been used to the lack of response. And in this study, essentially, you see up to a third of the patients actually having a response. And not only that, you see about a third of them who have a response, but we do see about 10% of the patients on average having a complete response, which is, pretty amazing in this disease. Having, treated this for more than 20 years, seeing CR, which we, I'm sure you have seen also in your clinic in the occasional patient, is incredibly satisfying. The median duration of response was also interesting at 18 months. So these are durable responses when they happen. Now, unfortunately, it's not 100%. We still have a way to go and learn about, the patients who do not respond and why they don't. When we look at the safety profile, it certainly favors atezolizumab versus sorafenib. Hypertension is certainly more pronounced with atezolizumab. With the Bev, more IRE, but overall, most of the diarrhea, PPE, decreased appetite, a lot of the toxicities that are more systemic were seen with the sorafenib group. And when you look at the patient-reported outcomes, they were certainly improved with atezolizumab versus sorafenib, and you see at the median 11.2 versus 3.6 months, and you see that is maintained beyond a year with the hazard ratio of 0.63. So it hits all the right elements. Then the next question is, so what happens when we continue to target the VEGF pathway, but here a little bit differently. Now we're looking at TKIs plus minus atezolizumab. The study Cosmic 312 looked at cabo-atezo versus sorafenib. And then there was a secondary arm with cabozantinib versus sorafenib with a PFS endpoint. And this was a secondary analysis. The primary analysis found cabo-atezo to have a superior PFS versus sorafenib, but survival was not much different between cabo-atezo and sorafenib. And in fact, when you look at the PFS analysis, you can see, again, at the median, 6.8 versus 4.2 month hazard ratio 0.63. So it looks similar to what we've seen with atezo bevacizumab. However, the overall survival did not seem to move further from sorafenib, and you can see pretty much similar here with a hazard ratio of 0.9. So unfortunately, this ended up being, half positive, half negative. But since survival was negative, this did not go to the FDA. The toxicities were as expected. Combining the TKI with a PD-L1 inhibitor certainly had more toxicities than the TKI alone. The other study that was highly anticipated in terms of its results is LEAP-002, which is a first-line lenvatinib plus pembrolizumab versus lenvatinib plus placebo study, and the patients were randomized to lenva pembro versus lenva, co-primary endpoints of PFS and overall survival, and essentially patients were treated until a progression or toxicity. The study was negative for both OS and PFS. Here I show OS, and you can see lenva pembro was superior, was about the same than Lenva placebo, hazard ratio 0.84, and then essentially at the median pretty much similar. It was interesting to see lenvatinib hit around close to 19 months, but I will tell you that, you know, in this particular study, patients with VP4, so those with worse potential outcomes, were excluded, and they were more aggressive about the EGDs. In this study, EGDs were obtained within 3 months of enrollment, and a little bit more stringent inclusion criteria. So this was a super selected patient population in that matter. The response rate was about 26% with the combo and 17% with single agent. So negative, unfortunately, and you know, and certainly did not you know, add value as such. So the other strategy, you know, to enhance the activity of anti-PD-1, PD-L1 would be to target CTLA-4 in addition to PD-1, PD-L1. And the thought here is, you know, you block the suppressive T cell signaling. You also expand the effector subsets. Also, you help or salvage a lot of these CD8 T cells, so cytotoxic T cells, from exhaustion. So essentially, continuously enhancing PD-1, PD-L1 activity. Oops. So based on you know, promising early signals, Himalaya was established as a very large study randomizing 1,300 plus patients to the STRIDE regimen, which was 300 plus D versus sorafenib, Durva versus sorafenib, and then there was a third arm or fourth arm in this sense, Tremi 75. So the Tremi 300 plus D, the STRIDE, was essentially one dose of Tremi, high dose 300, a priming dose. The Tremi 75 plus Durva was essentially 75 milligrams every 4 weeks for 4 doses plus Durva. Now, this was dropped ultimately because the phase 2 randomized study did not meet its primary and its endpoint that would essentially allow T75 and D to move forward. T300 plus D ended up being the one that they moved forward with, was powered for superiority versus sorafenib, where Durva was powered for non-inferiority. The study essentially met its primary endpoint of overall survival, but STRIDE Tremi 300 and Durva did not perform better than sorafenib when it comes to PFS, meaning that PFS was negative in this study. There's a little bit of a tail end, but frankly, you know, the curves are pretty close together, which explains the 0.9 hazard ratio. So although PFS was negative, the primary endpoint of overall survival was actually positive. And you can see the median here, 16.4 versus 13.8, a hazard ratio of 0.78. I think it's important to note that in this study, EGDs were not required. Now, that doesn't mean that EGDs were not performed. They just were not required by the study. So we don't know what percent of patients did or did not have EGDs. The other thing that's noteworthy here is that patients with, you know, who were included in this study had a VP4 excluded. So they excluded the patients with VP4. And we'll look at what that implies, you know, when we summarize some of that data. Now, I think it's pretty interesting to see that durvalumab as a single agent did almost as well as the STRIDE regimen. You know, putting in question, do we really need to combine Tremi with Durva to get the results? Now, this was a non-inferiority piece here, and it did meet the non-inferiority boundaries, which means, you know, durvalumab was, or this component of the study was positive. These are the responses, and you can see about 20% of the patients will have a response, whether on the STRIDE or Durva alone versus sorafenib, and these responses tend to be durable. So another study that's ongoing is Checkmate 9DW, and that's looking at a low-dose Nivo, high-dose IPI based on phase 2 randomized study versus sorafenib or lenvatinib in first line. We won't hear about this study for another couple of years. The primary endpoint here is overall survival. So we'll see where this will end up, especially intriguing is going to be the level of toxicity, since they're using a higher dose of IPI and a lower dose of Nivo in this study. So let's look at the phase 3 studies that were positive, and then the two, 150 and Himalaya, are the only two that are approved by the FDA. Cosmic 312 was technically positive, as statistically at least, since it was postulated on the study that only one of the co-primary endpoints needed to be positive for the study to be positive. So technically the study is positive, but because survival was no better, this was not pursued any further. But looking at IMbrave 150, Himalaya, and Cosmic 312, what becomes obvious is that overall survival was better with IMbrave 150, was better with the Himalaya, but was negative for Cosmic 312. Whereby with PFS, again, it was positive for IMbrave 150, negative for Himalaya, positive for Cosmic 312. So with the VEGF inhibitors, you get a positive PFS, but certainly with IMbrave 150, you have a very favorable overall survival and a positive survival with Himalaya. And you see the responses here and their durability. When we move down, lower down with the toxicities, as you would expect, with the STRIDE regimen, you do see more immune-related toxicities, 20% that require steroids. So these are, more severe toxicities. I mean, that's not surprising. You're doubling up on the IO. Now, when it comes to bleeding, what is obvious is that when you look at the grade 3 and 4 bleedings events, they're very similar between the atezolizumab and sorafenib. The difference is probably mostly with the grade 1 and 2, especially with bevacizumab, quite a bit of epistaxis, grade 1 epistaxis. Now, with Himalaya, the bleeding events were lower with STRIDE versus sorafenib. But I think it's important to put this in perspective, and in the perspective of excluding patients with VP4, you do see a lower risk of bleeding when you compare the sorafenib arm with Himalaya versus the sorafenib arm with IMbrave 150. You can see big differences in historical outcomes, which I think is pretty interesting. Meaning, by excluding those patients with VP4 involvement, Himalaya essentially excluded those patients who are at the highest level or highest risk of bleeding, which is a bit unfortunate, frankly, for us, thinking that this is where we would like to have a regimen like STRIDE, is in those patients with higher risk of bleeding, yet those are the same patients who were excluded from the study. So that certainly does not help us much in terms of understanding the risks. Well, but we have to come up with, where to place all these things when we actually end up treating our patients. So think about all your patients with HCC for first-line therapy. First, those, who may have undergone a transplant, a solid organ transplant, or those with severe autoimmune disease. Those patients, would not be eligible for IO-based therapy. So these patients would get lenvatinib or sorafenib. So if you're at Mayo Clinic, where we do tons of transplants, I see quite a few of these patients. The majority of the patients with Child-Pugh score A and Child-Pugh B7, essentially, and when I say Child-Pugh B7, I take this with a grain of salt, meaning those B7s that have very solid performance status, so 0, maybe 1, those would be eligible for atezolizumab, and that's going to be the majority of your patients. And then for those patients, essentially, that may be at higher risk for bleeding, and we're talking about essentially patients who typically will have a lower liver function, so a lesser liver function, which technically were excluded from some of these studies. But theoretically, at least, those patients where you're really, really concerned about the risk of bleeding being severe, then perhaps the STRIDE regimen. Now, we all have these patients that essentially, do not want to travel for IV therapy. They prefer oral therapy. For those patients, convenience is more important. I think lenvatinib remains a reasonable option. Not preferred, but reasonable. For those patients where you actually need a really good and strong response because they're symptomatic and they have a higher tumor burden, atezolizumab is definitely preferred, where you get, stronger and deeper responses. For those patients, who may be asymptomatic, perhaps lower tumor burden, but I think more importantly, those that may have had very recent bleeding and you still want to treat them with IO therapy, or those that had, say, an MI in the month or two prior to presenting with HCC, perhaps stride regimen would make the most sense. And there are other scenarios, one can think about, but these are, the most common scenarios. Now, moving on to second line, we have essentially 3 agents, 4 technically. We'll talk about the 4th in just a tidbit. But 3 agents, that were looked at in second line. Now, important to keep in mind that those patients were essentially patients who failed prior sorafenib. We don't have studies in the settings of prior IO. We don't have studies in the settings of prior lenvatinib. The only studies we have are with prior sorafenib. So Celestial looked at cabozantinib versus placebo, and essentially allowed up to 2 lines of therapy. So when you look at all the patients versus those that received it just in second line, it is obvious that those that received in second line had a little bit better survival. I mean, not surprising, right? I mean, you treated those patients a little bit earlier in the line. PFS was actually interestingly high with cabozantinib, close to 5+ months versus 2 months with placebo. When you look at regorafenib, you again, survival very similar, and you can see the PFS 3.4 versus 1.5. And then ramucirumab was only looked at in the alpha fetoprotein more equal than 400, and median PFS was slightly evident. Now, it's important to note that when you look at alpha fetoprotein more equal than 400, those are the patients, again, with worse prognosis. They did look at cabozantinib and regorafenib versus placebo in subgroups of patients with alpha fetoprotein more equal than 400, and did show consistently that those patients actually do benefit from cabo and regorafenib, whether they were less than 400 or more equal than 400. Ramucirumab, on the other hand, did not seem to work for patients with alpha fetoprotein less than 400. So when you look at all the agents beyond first line, we talked about rego, cabo, ram. Now there's also pembro versus placebo. This was, a negative study, or slightly positive when you add the China-only study to the rest of the world study, and ultimately this kept pembro as a single agent approved by the FDA, unlike nivolumab that was pulled out. When thinking about, all right, what do we do with those patients who receive prior IO, and now we think about, one of the TKIs. The only data that's available to us right now from a large prospective trial is actually a little subgroup analysis that came from the COSMIC study, the initial COSMIC study, that ultimately, allowed up to 2 lines of therapy, and there was a small percent of patients that received essentially prior anti-PD-1 or PD-L1 before receiving cabozantinib. And I think with a grain of salt, one would say that there is no detrimental effect from prior IO to cabozantinib. So whether prior IO or not, patients did relatively the same for survival and progression-free survival. Okay, so now with all this data, we have to pick an option for our patients post atezobev or durvalumab. So how do we think about it? We don't have clinical trials. There are some retrospective analyses. We just published a couple of those from our group at Mayo, and there are others as well. But there's no prospective trials that looked at the question in a randomized way. So we look at the theoreticals. Most of your patients are going to receive atezobev, so beva is not an option in the second line. Ramucirumab is not a preferred option. One, because it hits pretty much solely the same pathway, and you're limited by alpha fetoprotein. IO post IO doesn't make as much sense. Now, I would say with durvalumab, it may be reasonable to use ramucirumab, although again it wouldn't be preferred since there was no prior VEGF exposure. when we look at the other TKIs, sorafenib, regorafenib, cabozantinib, and lenvatinib, sorafenib is certainly an agent that we're glad not to use anymore for the most in clinic. Lenvatinib is more of a VEGF inhibitor, has not been frankly looked at in the second line post any agent. And so it makes it a bit difficult, to decide on that. And plus, we have other options, and the options are regorafenib or cabozantinib. Both, have shown results that are reasonably good post sorafenib, so post another TKI with a VEGF function. Personally, my preference tilts towards cabozantinib, and primarily because it does hit MET and AXL. This is from the renal cell cancer literature. Preclinically, it seems to reverse the resistance that develops to the VEGF axis by upregulating MET and AXL. And so, post atezolizumab, my preference had been to use cabozantinib, although I think regorafenib is also a reasonable option. And we did publish this in 2020, which is and this was before STRIDE, was with atezolizumab, and did confirm that regorafenib or cabozantinib would be two reasonable option post in the second line. So, atezolizumab seems like, the preferred standard of care for first line from the data that's been shown. I think there are some patients that may still be eligible for a STRIDE, and so it's important to have that option available. And then you have the patients who may not be eligible for immune therapy, transplant patients. These patients would be considered for sorafenib or lenvatinib. In the second line, overall data favors cabozantinib or regorafenib. You have other options, but again, for second line, that would be probably best. Chelsea QB score, we have some data with nivolumab, which unfortunately was pulled out, at least by the FDA, remains accessible, and then sorafenib, which is less preferred. But as we think further, about the overall patient outcomes with these therapies, it remains puzzling that despite all these discoveries we've made and the improvements in outcomes, we still can't select those 30 to 40% of patients who actually do benefit tremendously from therapy at the expense of others who don't. And also moving some of these advantages to earlier diseases. And, we've seen what 21, 22 brought. And then in 23 and beyond, next year or so, we're going to see some data with nivo-ipi, but a lot of data that's going to come about with local regional therapies, adjuvant, neoadjuvant therapies. One already reported out, that's EMBRAVE 050. And this is a study that was presented at AACR looking at patients that were considered high risk for recurrence, such as larger tumors, more than 3 tumors, aggressive pathology, etc. And those patients essentially would undergo either ablation or resection with or without adjuvant TACE. And then would be randomized to atezolizumab or active surveillance with a primary endpoint of recurrence-free survival. And picking the recurrence-free survival rate was primarily because those patients on active surveillance with this high risk of recurrence group would certainly see IO and most likely atezolizumab at the time of progression. So crossover was permitted. And this essentially is why OS was not a primary endpoint here. And this study did meet its primary endpoint of RFS, and you can see the difference is certainly there. Now, both curves did not meet their median. The hazard ratio is 0.72, and it is statistically significant. So it's a positive study in that sense. Still waiting on the overall survival data. The main questions are of course, what are the implications of this on our practice? How do we select the right patients that would ultimately go on the study? How to define high risk, which we know is not a very, there's no easy way to define high risk for recurrence. I suspect for most of our patients, where we think the risk is high, whether through established criteria or through clinical assessment, Atezobev would be a reasonable now standard to use in the adjuvant setting. In the reality, a lot of these patients will recur despite the adjuvant therapy, and so the question is again, what do you do eventually with those patients who you would receive atezobev? The rule of thumb is, if they recur within 12 months from their last dose of atezobev, then I probably would put something like cabozantinib. If they recur beyond 12 months, around that time, I probably would still think that they're immune competent and would re-challenge them with atezobev. And the other question is, of course, is this going to be applicable overall to the practice in the community that would see these patients? What level of involvement with tumor boards? Are the interventional therapists, the surgeons, are they gonna actually refer those patients to you at that point? So it'll be interesting to see how folks react to this data. All right, moving on to the cases. All right, so this is a 68-year-old man with a history of HCC. HCV, and alcoholic cirrhosis, so 2 risk factors in the right hepatic lobe. Now Charles Pugh B7. HCV was treated with remission, and then treated again with TACE Y90 TER 4 times over the past 4 years. Has a history of coronary artery disease, assuming that at this point, this is stable. So now progresses again, I guess, on TACE TER, and was referred to oncology for discussion of systemic therapy, which is now involving the diaphragm. So most recent imaging showed a larger hepatic dome lesion with invasion of the right hemidiaphragm. So stage 3B, not that matters. I mean, that seems like a large and intense tumor. I'm going to assume that the patient's performance status is 0 or 1. And Charles Pugh B7. Here's the conundrum is, the data from IMbrave, the IMbrave study, or all the other studies have excluded patients with Charles Pugh B plus. But in my practice, Charles Pugh B7 with a good performance status, that patient, has done well over the years. I'm assuming still well preserved. I would probably want to go with atezobev, and one of the main reasons is actually I want to see a strong response. I'm a bit concerned about the size and the level of invasion into the right hemidiaphragm. So my hope is that with this patient with atezobev, I would see a good response that could potentially get the patient for another local regional therapy ultimately after a few months of treatment. So I'd say atezobev. The other option would be if the performance status is 2, 1+ to 2. I may consider durvalumab, although would expect a lesser response and lesser activity overall, but that would be reasonable if there's concern about the higher level of toxicities. So YM is a 49-year-old female with history of HCV, asthma, liver cirrhosis, anemia, and thrombocytopenia. So again, HCV here was treated in 2018 and assumed complete remission. In February 2023, the patient showed 2 hepatic lesions by ultrasound. So one is 2.5, one was 2 in adjacent segments, consistent with HCC. She had RFA to the lesions, and a biopsy prior to that confirmed HCC. And assuming that the RFA was successful, but not completely successful. So she is considered to be a transplant candidate. With that IMbrave 050, would I treat her if she is on the list of transplant? So the short answer for this would be if she's actually on the list, meaning I don't know exactly when she's going to get that, depending what part of the country she's in. She may get the transplant quick, or it may be deferred. But regardless, given that with IO-based therapy, you need at least 9 to 9 weeks, preferably 12 weeks from the last dose to feel safe to challenge a patient with IO and then go to transplant. The fear of rejection, of course, is the biggest fear here. I probably would not give this patient atezo-bev. I may consider lenvatinib. If she had a great response with RFA, I would do nothing, just observe until she gets to transplant. If the response is suboptimal, I would do lenvatinib. On the other hand, if for whatever reason the patient was considered borderline and not transplantable, I would actually definitely do atezo-bev until the point the patient would be deemed, and we have a lot of these patients in our practice, until the patient is deemed to be transplant candidate, then I would stop it. And depending on the level of response, either continue with lenvatinib or with observation. But with atezo-bev, we've gotten a lot of patients downstaged to get to surgery or even to become a transplant candidate. But the rule of thumb is you need about 9 to 12 weeks from the last dose of atezo-bev before you proceed with a transplant. Okay,
Let's go ahead and stop there and see if there's any questions.
Yep.
Hey, Dr. Sam.
Hey, Wayne.
Hey, and I did not have a chance to send my case, but I appreciate that we have a chance to discuss about some cases here.
Yeah, go for it,
I have a 72-year-old lady who initially presented with metastatic liver cancer with history of liver cirrhosis with unknown reason, atrial fibrillation, and not a candidate for anticoagulation due to the bleeding risk, and also with a history of stroke. And initially, because she was concerned for some like a vascular invasion, and she was not a candidate for, well, at the beginning for TKI. So I put her on nivolumab. For the FDA actually withdraw that medication.
Yeah.
And then she was actually responded and has a relatively durable response for almost 1.5 years. And then her liver lesion actually progressed. Even her lung disease was totally under control. So then we did a Y90 treatment, and she was able to continue the nivolumab till now. But now the liver lesion actually progressed again, and the lung disease is still stable. So at this moment, and I'm thinking about continue the nivolumab, but maybe add a TKI like a swaplib or something. And
to the nivolumab, add the TKI to the nivo.
Yeah, since it seems that the liver is control the lung disease pretty well. It's just my thought. I'm just kind of like between the adding a TKI versus just discontinue nivolumab and use a TKI.
Oh no, I mean I think so the lung area seems to be under control, correct?
Yeah.
And the rest seems to be progressing, which is not unusual, right? The lung tends to be a more immune competent milieu, which responds more favorably to IO-based therapy. So I think it's a good idea to keep IO. And then the question is, what TKI can you add to nivolumab? Regorafenib comes to mind, right? Because there's quite a bit of data with Rego-Nivo, although the toxicities are pretty horrendous. So probably go with a lower dose. Asian descent. Yeah, so I would start with 80, and many patients on these studies that are of Asian descent had to even go down to 40 and still did maintain benefit. Although 40, is a dose that's technically not active in the overall population, but I think it actually for many patients you need to go down to 40. So that's one option. The other option was just to switch completely to to something else, either atezo-bev, which maybe, but also you could consider ipi-nivo, so adding ipi to nivo, and that way, before even you consider a TKI, it may be reasonable to have a CTLA-4 inhibitor on board. But I do agree with you that the most reasonable option would be to see if you can add a TKI, get the rest of the disease under control. Because it's nivo, most of the data that's looked at combining nivo plus had been with regorafenib, and that's probably what you would consider, which does have its activity in this disease. So I think that's a reasonable line of thinking. I would keep the IO though.
Sure, thank you.
Great.
Hey, Dr. Vaccaro, I was just curious, what's your preferred starting dose for Cabo in the second line?
Oh, yes, Gina, how are you? 40 milligrams. I rarely end up in 60. Most of the patients will just stay on 40.
Do you think, like, if a patient progress on atezo, I didn't feel comfortable to start BAV because of the esophageal varices, and then progressed, could not tolerate carbo. I tried carbo. I think his Child-Pugh score was Downson between 7, 8.
Okay.
And I started carbo when it's probably 8, and he ended up with encephalopathy after 1 week on the drug. So he's he looks much better than his paper. He has a lot of comorbidity, but he still mows the lawn and he helped his wife.
So good performance status.
Yeah, so I put the patient basically on hospice right now. I'm just thinking, in this situation, would you ever consider, to challenge the patient with IO and tablets? Because he basically cannot tolerate anything else and has a very, very strong will to live,
Yeah, no, I mean, that's such a challenging case. One of the problems with the TKIs is that they do hit VEGF and they do have a risk of bleeding with them. So you're not diminishing the risk of bleeding. But if you want to go with a TKI plus IO, so you have two options. You have since you know that atezo was safe enough with this patient, you could add cabozantinib to atezo. You don't expect a significant response, but it certainly can give him, PFS was positive on the study. So there's certainly a number of patients who had delay in progression. You could consider lenvatinib, pembrolizumab, although I don't think I would go down that route because it didn't hit any of the points better than lenvatinib. So I'd say cabo atezo if you want to stick to the atezo, and just instead of doing beva, you want to do a TKI, and the TKI has its own level of activity as well. So I would do 40 milligrams of cabo with atezo. If you decide to treat the patient.
So would you consider tremi and durva?
I wouldn't. The reason for this is, I'd be really concerned about dual IO in a patient with a Child-Pugh score of 8+. I'd be concerned with a single agent, and lo and behold, doubling up. So I'd be a bit nervous on that.
Thanks.
Okay.
Okay, let's go ahead and wrap it up.
All right.
I'm sorry.
No, okay, great. Thanks, John.
Yeah.
Thank you all.
Thanks everybody for participating tonight. I hope you found the presentation useful, and I hope everyone has a pleasant evening until next time.
Thanks all. Take care.
Thank you so
All right.
much.
Bye-bye. Thank you. Bye.
Thank you.
Bye-bye.